more people joining. We know that there are a lot of people signed up for this webinar, and that's really encouraging because it means that a lot of people care and a lot of people are trying to find ways to be well and stay well in the maternity arena. So some of you might indeed be watching this after the event, but hopefully the questions that come up from others will help you in your thinking. So I'll introduce myself and Florence will introduce herself. And then we are going to get into a little bit of discussion along the way, which we can include you in as well. So my name is Kate Greenstock and I'm a midwife. I was trained in the UK, currently living in India, working as a midwife here. But my real passion as a midwife is thinking about what it means to be trauma informed, but on behalf of ourselves as people and colleagues. And I have written a book called Flourish, a practical and emotional guidebook to thriving in midwifery that came out in 2023, which was bringing together words, vocabulary for explaining the psychological challenges that we face in midwifery, but also bringing my coaching life, I'm also a coach, into the book to help us to think about who we are as people and how we therefore navigate the life as a midwife and navigate the psychological challenges, how we stay well in the day-to-day and for the long term. So yeah, midwife and coach and mother, and you'll all be curious now, currently living in India, but very firmly based in the UK. Florence.
Hello, my name's Florence and I'm a consultant obstetrician in Southwest London, and I've been practicing in the NHS for a terrifying 30 years now. And I'm also a podcaster, so I have a podcast called the Obs Pod, which is kind of a bit of a hobby, but trying to kind of explain to other members of maternity staff and families using services what is going through an obstetrician's brain with various different problems and complications, and what is my life like. And I've worked with Kate for a number of years before she disappeared to India, and I'm very much hoping she's going to come back at some point. But I felt like her book, Flourish, suddenly called out all sorts of things that are mainly unsaid. There's very little in medical training more generally, and there's very little in obstetrics or obstetrics and gynecology about psychologically how the day-to-day work might impact on you. And I have had a couple of episodes of mental health issues myself, which some people know about and some people don't. I've always been very open about it, but I wanted to join Kate when she asked me about doing this webinar with her, because I feel it's really important that we can talk about our own mental health, and particularly when we're not okay, to be able to talk about it and get support from people around us. And I know it's a kind of cliche, but it's okay not to be okay. But sometimes it's really hard to understand and realize and recognize that you are not okay. And certainly for me, both times I've been more seriously ill, I've needed other people to tell me that I wasn't okay.
Yeah, thank you. And thank you for mentioning, those times, because they're very visceral and also reflected, I'm sure, in the lives of many other people who are joining us. I too have a history in terms of my mental health. For me, manifesting particularly after the birth of my first and second baby. And I had what I didn't really recognize at the time, but was postnatal anxiety that manifested in, trying to control my world. And interestingly, in my midwifery training and in my first few years of being a midwife, I noticed some of the triggers for me, which maybe I hadn't fully acknowledged, like overstimulation, environments that are very noisy and very bright and that involve like constant change, but actually being quite hard for me. So my sensitivity to the world and to my environment, I recognized more clearly, I think, through midwifery training, but was then able to reflect on those early years of mothering as well. So yeah, we all bring, don't we, our stories and our mental health stories. And they're often the things that get slightly neglected as we come into these professions, even though the fact that we have those stories make us even more likely to want to be in these professions. And the fact that we're in the profession makes us more vulnerable to being triggered into whatever we're sensitive to.
Yes, absolutely.
So we thought we would join you, everyone, with a conversation about this, and that we would break it down into three parts predominantly, but we're also happy to be led by you. As Fatu has said there, we would love you to put your questions into the chat as we go, and then we're going to have more of an open question and answer session at the end. So we're going to start by just acknowledging the psychological challenges of the work. Now, when I say the work, it sounds like it's got capital letters, doesn't it? I'm talking about midwifery and obstetrics and maternity support work and bereavement work and nursing, intensive care nursing, or whatever is in the maternity space. There are many roles within the maternity space. So we're going to start there. And I'm going to describe some of I call them in the book, mega mountains, which are the psychological challenges. And then Florence is going to tell us a little bit more about her story and what it's meant for her to live inside her body and brain, and what it's meant in terms of the impact on colleagues and from colleagues in these times for her, and what it means to be an obstetrician working in maternity. And then we're going to look from a combined perspective on being together, supporting each other, what it means to work as a team, an integrated team, a multidisciplinary team, and to be looking out for each other, and how we might expand that into creating opportunities, creating settings where we can really hear each other, really learn from each other, and share the deeper parts of our lives and our stories, and how that might be able to facilitate change in the system. So that's where we're going. Anything, Florence, you want to say there before I kick off with the psychological challenges?
No, I think starting with the psychological challenges is a very good place to start. And I think a lot of what we're going to say, yes, this is billed as maternity, but a lot of what we're going to say also applies to all sorts of other areas of medicine and healthcare. You know, I think when I started my house jobs, I was thinking about this the other day. When I started they were called house jobs, they're now foundation program. And my first patient died. I literally ran off the ward to the consultant's office to try and find him, to tell him that this terrible thing had happened and this person had died. And the secretary was like, what are you doing? You know, why would he want to know that? Almost not, I mean, she didn't say why would he want to know that, but it was kind of like I couldn't understand how everyone else thought this was completely normal. So yeah. I think starting with if you were outside healthcare, you'd think that was a major thing, someone dying. And it shows you how unprepared I was as a young doctor. So I think starting with the psychological challenges is a good place.
And actually, even as you said young doctor, I was thinking young human. You know, that's who we are. We're coming into this as humans, not only with those stories, but just with the personalities and the humanity, which of course it's a shock and a major event in our lives to have someone die around us, let alone in our care.
Yeah.
And yet it becomes normalized that, yeah, that's what happens around here, right? And a lot of what we're talking about is that's what happens. This is what this work involves. It's what happens in here. And the cultures that we work in start using the same phrases, overtly or covertly, of, yeah, that's how things happen around here. So I am going to talk about psychological challenges, and I'm also going to point out the fact that we might have student midwives on the call as well, or student doctors, or other people in training. And we're really grateful that you're here, because this starts from the beginning, right? We're grateful that you can begin to acknowledge for yourself, but also for your co-students, that these things are real, that when you're experiencing the almost culture shock of being in a healthcare system for the first time, you're not making it up, even though sometimes it may feel that way, that you're not crazy, and you're also not being over dramatic when you acknowledge that things are hard. So we're glad you're here, and hopefully with everyone else, we'll get to take away some helpful foundations, some vocabulary, and also some ideas for connecting with colleagues. So I'm just going to go through one by one. There's only 5, don't worry, but 5 mega mountains, as I call it, in this book called Flourish. And I've called them mega mountains because the metaphor of the book is that we're walking up these things, experiencing moral injury, compassion fatigue, burnout, trauma exposure generally, and also PTSD or PTSI. And that as we scale these mountains, we experience hardship. You know, it might be lack of oxygen. That's what it feels like to be on them and in the experience of these mega mountains. And also, to extend the metaphor, that it's quite hard work to walk through that landscape, knowing that at any given time, I might be, experiencing burnout, a colleague might not be, but they might be in a different place, and that we need to somehow connect with each other despite being in different places. But also that we need a backpack with us, not a one that's too heavy, but one that has things in it that are going to support us along the way. And they're the tools and the ideas and the connections that we have that are going to enable us to survive. Might be the bottles of oxygen that will survive us in these harsh terrains. And let's face it, maternity is properly a harsh terrain at the moment. And you can see it in the newspapers every day. Debate in Parliament on Tuesday morning about the state of maternity services. This is a live issue, and there's also good stuff happening, very good stuff, but we can't deny the impact that it has on us psychologically to be caring for others. So the first mega mountain is moral injury. And the reason I put it first is that it's the mega mountain that most midwives and others who've read the book feel connected with. They're like, oh, that's a thing, I feel it, and yet I never knew how to express it. So it is the sensation of working against your own values, of being, in a sense, forced to do something that you don't really agree with. And it was first talked about in military terms after the Vietnam War, and then first Gulf War. It got sort of expanded and talked about. Only around the time of COVID did we start to talk about moral injury in healthcare. And then even later, really, in maternity. So it's really significant, because in maternity, it might play out, for example, in terms of facilitating an induction on the antenatal ward, even though you know that there may be very thin or no justification at all for an induction. And yet, because the process is there and the institutional drive is for this to happen, and because the parents are already expecting it, you go ahead with that. And you facilitate a consent process, but maybe you haven't included absolutely everything because it takes time to do that, but also how are the parents going to feel when they're already bought into this process? So that involves, that forces us into a position where we're experiencing moral injury. It might be the vaginal examination that due at 3 a.m. That's what's written on the board after all, when actually there may be good reasons for not doing it at that time. Maybe physiological reasons, there may be emotional reasons. We may even have some sense that this woman is one of the 1 in 10 women who have experienced childhood sexual abuse. Who knows, right? We may know her story, we may not, but there may be many good reasons for not doing that vaginal exam, and yet we do it anyway because it's kind of what's expected of us. And we're conforming to the institutional norms and guidelines. And, they're good things too, but not necessarily individualized. So again, moral injury begins to build because of persistent situations where we're feeling powerless as practitioners and having our power stripped from us as we proceed with decisions or interactions that are essentially going against our values. In COVID, obviously really difficult saying no to partners and family members, that they in some units in particular, there was a big no where partners couldn't be present for the birth of their babies, but certainly in the postnatal ward as well. Even that is a morally injurious situation. And of course, intensive care nurses and doctors were experiencing that in a maximal way with having to engage across screens with partners and with family members. So that's moral injury. And maybe some of you have questions or thoughts on that. And if you do, please put them into the chat. And I've only given a very brief description, I know, but I'm sure all of you will relate to that feeling of like, I want to be able to practice as I was trained to do. I want to be able to give this person what they need in this moment, and yet I can't. So the second mega mountain is, I could go in any order really, but compassion fatigue. And this is that feeling of just almost withdrawing in your body and your mind because you've got nothing left. And I use this description of myself wearing one of those very 1980s tabards that say, do not disturb, drug round in process or progress. And I was wearing this particular tabard on the postnatal ward and coming around doing the drugs round, but I was using the tabard as a way of retreating. And it meant that as I came into the room to give some drugs, and I would see that look on someone's face, which said, I need something now, I would sort of be flashing my chest and the tabard at them, going, I'm just retreating out of the room at this moment because I've got nothing to give. And that's shameful as a midwife to admit that, and yet totally true. And I also talk in the book about the fact that when I get home from a shift like that, I have got nothing to give. I've got no compassion for my children. And especially when things are blowing up, there are emotions in the mix. I can't engage with them. My husband would often say, where are you? And I'd be like, I don't know. I'm not really here because there isn't anything more. And that is that sort of soul destroying feeling of like, I'm not me anymore. I'm not here in my body and in my mind because I've had to disengage in order to keep going. There's lots more I could say about compassion and empathy and how the two work together, but let's move on to burnout, because burnout distinguishes itself from compassion fatigue in two ways. Firstly, that it is a occupational, not just an occupational hazard, but it is an occupational disease. It's classified in the OECD as an occupational disease. So we can go, wow, that's an actual thing. And there are validated tools to assess where you sit on the scale of not burnt out at all to absolutely burnt out. So we use it in common language to describe, feeling a bit off. But actually, it's a real thing that can be assessed, and that perhaps in maternity, we need to be assessing more in our regular connections with others doing an annual review or just in supervision, or any opportunity really to say, where are you? Am I, if you think about it in color, am I in the bright red or orange, or am I actually in a yellow or green place, which feels a little healthier and where I can focus on looking after myself and connecting with others. Burnout, the important thing to remember about burnout is that it's not one thing. It's like the accumulation, as Leah Hazard calls it, of little fires burning over time. And what it's doing is having an effect on our nervous systems. It means that actually we are in an almost permanent sympathetic nervous system state. And we find it more and more difficult to activate our parasympathetic nervous system and the connect and the digest and the rest and the, oxytocin and dopamine fueled restorative systems in our bodies. I think I'm going to leave burnout there. But again, you may have comments or thoughts on burnout that you want to share or questions that you want to ask. And the final two mega mountains are trauma exposure and then post-traumatic stress injury, as I like to call it, rather than disorder, because it shows that it happens to us. So very briefly, trauma exposure, I think, is really important for us as maternity practitioners to think about, because it's that stuff that keeps coming. It's the stories, it's the families' lives, it's the events which aren't necessarily the biggest ones, but the ones which we have experienced as traumatic. Maybe because there's been some moral injury there, the family is saying, oh, that was all fine, I'm really grateful for my healthy baby, but we know things could have gone differently. Or it might be that actually things are, for us, objectively challenging or traumatic, but no one else is acknowledging it. Because like Flo said about her example of being in her foundation years, everyone else is like, well, yeah, that's just what happens, right? So that the accumulation of this stuff, including other, the stories of our colleagues who come to us and go, oh, you can't imagine how much how much she bled, and without perhaps proper permission to be sharing stuff in this way, describing emergencies, describing shoulder dystocias, we start to accumulate that stuff in our bodies and minds, and that can create this trauma exposure effect, the symptoms of which can be burnout or compassion fatigue. So you start to see how trauma exposure, which might be linked to moral injury, has the other kind of roots, and then the symptoms are compassion fatigue and burnout and PTSI, which is the last one. So post-traumatic stress injury, most of the research on midwives seems to show that about 5% of midwives are experiencing some kind of clinical levels of PTSI. That's really high. And the survey that the team at Liverpool University did, which is called the Indigo study in 2020, looked at over 1,000 obstetricians, and they came up with a stat of 18% of that body, that sample, were experiencing clinical PTSI symptoms. So we're talking really big numbers, and we're talking, flashbacks, re-experiencing of events, which can often be very visceral and impossible at the time after the event to rid yourself of mentally. And we're talking, an inability really to connect to anything other than that event in the immediate aftermath. Now, of course, that to some extent is normal after an event. Your brain is doing this incredibly clever thing where it's trying to sort the memories which cannot go into the long-term memory store until you have made sense of them. And yet that process takes time. So in that first month, it's normal to be feeling some of those things. But after about a month, it's not normal anymore. And what we're trying to do with the work that we're doing is to say, what would it be like to intervene well enough and early enough to prevent PTSD or PTSI from becoming a more permanent, anxiety fueling, vigilant approach to life, with those symptoms manifesting more strongly. So one of the things that we've created out of the book is a trauma exposure poster, which can be personalized to the trust that you're in. And this could of course apply inside or outside of maternity, but it's getting you to think, well, what does it mean to, after an event, to sit with your feelings with someone you trust, to know what's normal, and then to remain in connection, and crucially, to seek support from either inside or outside of maternity, to speak to someone that you trust who can offer robust professional support. So that's a very rapid overview of the mega mountains, the predominant psychological challenges of our work. And I hope that, well, I hope they're not recognizable, but I suspect they are. And if they are recognizable, I hope that even just hearing them and hearing them defined helps you to go, ah, it's not just me. These things are real, and they are, yeah, there are words to describe them that I can also then translate into my conversations with others.
Yeah,
Any thoughts, Flo? Yeah, go ahead, Flo.
no, I was just going to say, it's like every time I hear you describe them or I look at the book, it's like tick, 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 tick. It's like, oh yeah, that's that time, that's that time. Um, it's, and I think the main problem, as I see it, is the complete lack of acknowledgement of it at all.
Mm,
And there's no at the beginning of the day or at the end of the day, where are people at? And that this is actually an incredibly psychologically demanding job.
yeah.
It's totally brushed over all the time. So yeah,
Mm,
I'm sure lots of people are recognizing lots of what you've just described. And hopefully, yes, naming it and acknowledging it is a useful exercise for people as a beginning, because I
yeah.
think what you said that resonates with me is the fact it's not you. It as in it's not oneself. We're not going mad. It's not normal to not be bothered by any of these things. And certainly for me, if I got upset or um, took things on or found my work had an impact on me, I was I was often told, "Oh, you're too emotional. You care too much." I can't tell you how many times colleagues or people have said that to me, and it
Build
took
a
me,
thick skin.
yeah, and it took me a really long time and being ill to understand actually they were wrong. Um, that wasn't correct, and it's more they're not in touch with what's going on around them enough,
Mm,
rather than it being me.
yeah. And actually, that slightly dissociated state, that slightly numbed state, is an incredibly clever survival strategy in maternity, isn't it?
Mm.
And of course, we numb in all sorts of ways, which might be booze or drugs. And Sally Pizarro's study on the number of people who are regularly misusing alcohol and drugs in maternity was very revealing, including the number of people who seem to be coming to work, sometimes under the influence.
Mm.
But we also might just numb by scrolling and, um, you know, binge watching stuff, or even just like recounting stories from work can be a kind of numbing exercise, I think, because you're sort of slightly processing it, but not really, because you're not really engaging with how it feels. You're just telling the story. I mean, there are all sorts of ways in which we can numb, but it's a sort of natural response, and yet can be incredibly painful when you're confronted with that. So I'm thinking about student midwives working with a practice supervisor who doesn't appear to be registering that any of this is a big deal, whatever's going on. and it can feel very disingenuous to be in that situation and witnessing that and go, but isn't this something we should be talking about?
Yeah, definitely.
So do you want to tell us a little bit more about your journey?
Yes, I mean, it's a little bit complicated for me because as well as working in maternity as an obstetrician, I was also I had a management responsibility within the organization. And so it was very stressful because I was trying to do half a week of clinical practice, so labour ward on calls, antenatal clinic, um, and half a week of hospital executive team meetings, running a division, etc. So um, by the end, it felt like I was basically running, like a military assault course you see on
Hmm.
television. You're training to be, I don't know, some super paratrooper or SAS. It literally felt like every day was this massive assault course. Um,
In
that
the
I
mud.
in the mud, running, climbing, and
Mm.
no idea if I would ever get through the day. And that's literally how it felt. And I think it felt like that because I didn't know when to stop. So I definitely had burnout. I definitely had compassion fatigue. And I only stopped because my body kind of went, nah. And I got stomach pains and I went to A&E. And after a few days off and some investigations that actually, pretty much things were fine, I suddenly thought, oh, maybe this is stress related, which in hindsight is so obvious. Um, I wasn't sleeping. I was waking up at like 3 or 4 in the morning, not being able to get back to sleep, stuff going around my brain, and feeling like I wasn't giving my best to anything. And um, yeah, it wasn't until my body stopped me that I thought, I'm not okay, and I was really, really not okay. Um, and it was very difficult acknowledging that because I've had colleagues, so I'd been a consultant for about 10 years, and in that time we'd had a number of colleagues off unwell, but unwell with things like cancer, you know, serious problems, serious physical problems. And I was the sort of person that, you talk about presentism where you go to work when you're ill. I would never have a day off for a cough or a cold or a whatever, you know, unless I couldn't physically stand upright, I would be in work. So the idea of being off sick for something like mental health was just totally alien to me. But I actually couldn't work. I couldn't think straight. I couldn't I was so anxious. I was shaking at the thought of going to work. I was absolutely petrified of even being on the hospital site. I just kind of fell apart. And the thing that really was difficult the first time I was ill was no one contacted me. So I'd been I'd been a consultant at the hospital for 10 years. I'd been working at the hospital for probably 15 because I was a resident doctor there first. And I got no messages. No one rang me. No one sent a text. No one asked how I was. Was I going to be back soon? How was I feeling? Was I all right? It was just literally like being erased. It's like I disappeared. I literally thought I was like a leper. No one wanted to know me. No one was interested. And I felt I have been killing myself, literally killing myself for this organization, and no one actually cares at all. How stupid am I that I've put myself heart and soul into doing this work and no one's even noticed I'm not there. Um, and I'm very lucky in that I got good support. I did go, I unfortunately we had sufficient money for me to go and get a private therapist. And I got a therapist, and then I was diagnosed with depression. I had to start medication, and it took me a really long time to come back. And the person that helped me the most was occupational health, because I have to go back to work. I cannot be off work. I can't, I'll never get back to work. I thought if I didn't do some work in the building, I would never get back to work. And so I did quite a few months of 2 days a week non-clinical with support of occupational health. Um, and they were absolutely right. I was rushing at it. I didn't want to take the time because I didn't think I needed the time, and I was worried about what will people think about me. And I think I said to you as well, you know, what about the women I care for? Do they want to be looked after by a doctor who's
Mm.
had depression and isn't okay or hasn't been okay? You know, you want to be confident in the person that's perhaps going to operate on you or deliver your baby or give you medical advice. You don't want to think, oh, they're a bit dodgy. Um, and there were times, I think, coming back to the kind of compassion fatigue and moral injury, there were times I remember someone saying to me, do you still want to be an obstetrician? And the really scary thing was, I went, I don't know. And for me, that was really shocking because I'd wanted to be a doctor since I was 14. I'd wanted to be an obstetrician since medical school. My job was everything. I absolutely love my job. And yet I'd got myself into a place where I didn't know and I didn't care.
Mm.
Um, but I did get back. You know, this is 6, 7 years ago now. Um, I did get back. Good things about having been ill and acknowledge having been ill is I've learnt much better how to have a balance in life. So work is still really important to me, but I've got more going on outside work. You know, I was thinking about what you said about when you come in from work and that kind of reset, because I'll come in from work and I'll reset by doing some yoga, or in the morning, I'll get up and I'll take my dog out, even if it's just for half an hour before I go in, because that resets my brain. So
Mm.
I've learned from being ill some tools that help me stay well. And it's interesting because um I had a relapse this summer, so very recent. And once again, I didn't really realize I was unwell until I was sitting on the labour ward thinking, I don't actually care, don't care about what's going on. And then I thought, that's not me, something's wrong.
Mm.
But this time it was really different when I was ill. I was off a lot less long, but everyone reached out to me. And it made such a difference to have messages going, you don't have to reply, but we want you to know we miss you. We just want to check in how you are. You know, do you want a coffee? Do you want to walk? And actually, I didn't want any of those things because I was in on myself, like you said. But just to know that people were thinking about me and that I had some value within the department made a big difference.
Mm.
But we're not open enough about the day to day, what we're all going through. And I think it'd be much better if we could be.
Mm.
And I
There's a
think that's
lot.
particularly, I mean, I don't know, I feel particularly doctors are bad at it. Like if there's a bad outcome, it's so often that the doctor is pretty much expected to carry on that shift, carry on the next day, carry on. And more often I see the midwives or nurses having some time off sick, maybe a few weeks, and I don't know what it is that makes us, in your book, I know you've got a lovely illustration of someone with a cape, we feel like we've got to be superheroes, and I don't know why that is.
Mm. And it's particularly prevalent amongst doctors, isn't it?
Mm,
And COVID kind of fed that superhero narrative a little bit as well.
yeah. I'm
So
conscious I've
interesting.
rambled on a bit and we've got not much time.
It's really helpful. We set ourselves the quarter, the 45-minute limit. We can actually go a little bit further. But I just found it really interesting talking about that feeling that you had of I just didn't care, and
Mm,
that really isn't you,
yes.
which I know. And I remember having that same feeling, having just finished my midwifery training, or maybe I was just coming to the end on birth center, which would normally be like a natural place of enjoyment and connection for me. It's kind of a home for me. I didn't want to go into a birth room because I just couldn't do it. I felt disengaged, and then I couldn't talk to anyone in that time in between finishing and qualifying and starting the job. Couldn't talk about birth, couldn't engage with anything on social media about birth, just didn't want to know. And I realized that I was burnt out. I could not engage, couldn't even talk to close friends about anything maternity related. So it's such a strange feeling to be so disconnected with yourself,
Yeah.
and the things that you would normally care about.
It is. It's very frightening actually because it
Yeah.
it because you've completely lost your sense of self. And I've had that both times I've been unwell. And it's been really frightening because it's like I don't know who I am anymore
Mm.
and I've lost it, and can I get it back? And the answer is yes, you absolutely can get it back. Both times I have got it back. But in that moment, it's like you're not in control of your brain.
Yeah.
It's horrible.
Yeah. Yeah. And the other thing that your story raised for me was a moment, and this takes us on to the third section of today, where it was probably not long after that first episode for you or period for you, where we connected in the corridor and just had a moment of, I felt you seeing me,
Mm.
um, and going deeper than the uniform or the status
Mm.
or anything else that was going on, and just connecting over the fact that we both knew. I knew a little bit about what had been going on for you. You knew a little bit about me, and we were able to just connect as humans.
Yeah, I think that is it's true. And I think there are just little things that help you connect with people, and you don't need very much, but you do see them, yeah, in a new way, isn't it? You get to know someone a little bit. Um, and that's really, really helpful.
Yeah.
And then you can tell when someone's not okay, but whether that's body language or how they're talking that day or whatever. And it might be, I've had this with an anesthetic colleague, you know, is it someone's unwell at home, or in theatre, someone's worrying about a child, or, there's other things going on in everybody's lives. And you don't need to know very much about anyone, but you've got to see them as a human. I mean, I, as you know, I was a big Twitter person and not so much now. But my Twitter bio says human, not robot.
Mm,
And that's for a reason, because I
yeah,
think a lot of our work, it is, we're expected to be robots, people without feelings.
yeah.
But I am a human being and I'll pick up if someone's not okay. And I want to make eye contact with people and I want to try and know their name. And I want to have that human connection. I think that's one of the things that attracts me to medicine and keeps me there, is that human connection. When it was lockdown, I felt really sorry for my husband and kids who were locked in the house, because I could still go out and go to work. Even though it was terrifying, I could still go and talk to people.
Mm, yeah, yeah. And actually, that feeling of being able to see someone's needs, so maybe the anaesthetist in the theatre, and we know from the human factors research out there that just acknowledging that someone might not be okay and having another human connecting with that then enables them to use less of their brain on the issue that's been unacknowledged and more on the stuff in front of them, the blood
Mm,
pressure or whatever. So this is a real safety issue as well, and sometimes the
mm,
two don't get connected. Like we
mm.
don't spend a lot of time saying what are the implications of the emotional labor and the psychological challenges for on the ground practical safety for the people we care for as well as ourselves.
Yeah.
But micro moments are definitely a thing, aren't they?
Yeah.
Like those micro connections.
Yeah. So I think when you're operating, say you're doing a cesarean,
Mm.
as the obstetrician, if it's, say you're having difficulty getting the baby out or difficulty controlling bleeding, it can be quite a lonely moment. No one can help you. It's your responsibility. You've got to do it. Everyone in the theatre is looking at you. Um, and it's a massive responsibility. Um, someone said to me, if you actually thought about what you did every day, you'd be paralyzed by anxiety. You wouldn't be able to do anything. And I know one of the nice things about working in the same place for a long time is if I'm in that sticky situation, I know that the scrub support workers, I mean, there's one particular wonderful one. She knows who she is. She's about to retire. I'm going to miss her so much because she anticipates my every move. She knows exactly what I want before I know it myself. And if I've had difficulty getting a baby out and I've got it out and I'm like heaving that huge sigh of relief, she'll just reach across and hold my hand, or pat my hand and go, well done, take a breath, or and that is what you need in that moment, to just ground you and think it's okay, it's all going to be okay, and I've got the
Mm.
team around me and we're all working together. Because it's a horrible feeling, particularly when you can't get a baby out, a deeply engaged um, head, perhaps a fully dilated section where you've struggled and not managed to achieve a assisted vaginal birth, and it's very impacted and it's a horrible feeling. Um, and just having those people around you, or the person that when you come out and you're a bit sweaty and a bit stressed, they've made you a cup of tea.
Yeah,
It's
it reminds
just
me of a
tiny things like that.
yeah, reminds me of a time after an episode in theatre as well, where the doctor involved sought out each one of the people who'd been in the room and just that made it her business to find everyone, which is no small feat in itself, but then also sit down with everyone wherever they were, just for 10 minutes, just to check in and go, how are you? And it was memorable because it was so distinctive.
Yeah.
And again, the sort of institutional momentum was to get people back into rooms doing their
Yeah, yeah,
thing,
yeah,
but
yeah,
she'd chosen something else in that
yeah,
moment.
yeah.
Um, yeah, I was also just thinking about what it means to have time together.
Mm,
So obviously we do prompt training or emergency skills and drills type training. Not everyone calls it prompt, where we get to work together as a full maternity team and figure out, movements, mechanics, strategies for certain emergency situations. Um, and we often will talk about human factors in that, but we don't get loads of time together just to talk about the emotional dimensions of the work or hear stories like the one you've just told from the
mm.
obstetricians, or for you to hear what it's like for a midwife in the room to have an obstetrician walk in and go, what's going on here then, police style, and
Yeah,
it, it doesn't happen very often, but it or take over or question the judgment over a vaginal exam or whatever, right?
yeah,
Or indeed assert something to the woman or family that you have not been asserting up till then,
yeah.
and that how useful it is to talk about not only our background stories as people, but also to do a I call it in my head e-prompt, like emotional prompt, where you
Mm,
get to work through the impact of events and talk about your own reactions and responses, but also talk about strategies to help each other as well as help yourself.
mm,
So my kind of invitation, I guess, to all of us is to say, how might we begin to rewrite the time that we have together so that we're making the best use of it in terms of staying well? And this whole webinar is framed as staying well in maternity is a radical act. Like it's not soft and fluffy, this stuff. It's inherently linked to safety of both the people we care for, but each other as well. I mean, Doctors in Distress is, one of its key uh, foundation stones is preventing suicide of healthcare practitioners. I
mm.
mean, this is it's so present and it's so real. So it's not the soft stuff, it's the hard stuff.
Yes. Yeah, I think that's really important because I don't I don't think people see it that way.
Mm.
They see it as the fluffy nice to rather than the kind of skeleton. The
Yes.
um so yeah, and I think your book, the sort of second part, some of those ideas about how you might check in at the beginning of a shift or do some things with someone you're working with that day to just kind of reconnect you to why you were there and why you're doing that job. And I think there was something about, is it intentional moments or something? I don't know. I can't remember what you called it, but now I sit in the car and think each day when I get to work, right, today's going to be good because I'm going to do blah, 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 setting that
Yes.
intention.
Yeah.
And so it's very small, little things that if we all did individually or together with our teams, could make a big difference to reducing some of this trauma, compassion fatigue, etc.
Yeah. Yeah. Amazing. So we have got 5 minutes left. So I just want to give the opportunity for people to. We haven't had any questions so far. That
Yeah,
might be
everyone's very
because
quiet.
you've all dropped off, or it might be because